Dr. Pruett. As we're moving on with our CEs this year, we're moving into some more medical topics now that we've tied up trauma and our respiratory emergencies. And today we're going to start with something that may be a little unfamiliar for folks, but we're going to talk about basic laboratory values and why that's important for us in the field. So we know that the life of the flesh is in the blood. The blood can tell us an amazing amount of information about what's actually going on in the body. So today we'll focus on that little purple tube there. The two tests that we're going to talk about are the complete blood count and the basic metabolic panel. But realize with the way that science is today, we can test just about anything that comes out of the body, whether that's urine or stool or any kind of fluid from a joint or the cerebrospinal fluid or fluid from the lungs or fluid from the belly or even microbiology type of fluid. We can gain an amazing amount of information about what's going on inside the body from these specimens that we collect. When we look at the composition of whole blood, so the blood that we pull out in that purple little tube, you can centrifuge it down, just spin it, and you'll see that about 55% of it is here in the yellow space, and that's called plasma. And what's located in the plasma is a whole lot of water, which we'll talk about later, but that's very important because that's the solution where all the chemistry happens in our body. But plasma also has some very important other products in it, namely all of the clotting factors and a lot of the electrolytes and nutrients that circulate around the body. So plasma is very, very important. And probably next most important is the red blood cells, and that's just a little bit less than half of the blood volume in an average adult. Now, red blood cells are important, we all know, because that is the main carrier for oxygen. That's about all that they do, but that's a very important job because our bodies and our cells absolutely have to have oxygen to do their job and to keep us alive. Pretty amazing to me is this little white thing right here called the buffy coat, and that's only 1% of whole blood. But what's in there is platelets and all kinds of white blood cells. That is our immune system right there, just 1% of the blood volume, but does an incredible job protecting our body against invaders and is very, very important. If you were to look at blood underneath a microscope, this is what a normal blood smear would look like. You see that the majority of it is those red blood cells that we talked about, so just a little bit less than half. They're spherical shaped, they're kind of pale in the middle, they carry oxygen, they look like they're doing a good job and they're the right shape and they're not too pale. All the yellow background, that's the plasma. And then the big purple cells that you see in there are actually different types of white blood cells. So you can see three big ones on here. You see one right here, one right here, and one right here. They're patrolling the blood looking for invaders. And these little purple flecks here that you see around, those are platelets. And they're also just patrolling, looking for places where they might need to initiate some clotting or help with inflammation. So when we talk about a complete blood count, you'll hear this referred to as a CBC. It's very simple. It's looking at everything we just looked at under the microscope. We're looking at the number of white blood cells. We're looking at the number of platelets. And then hemoglobin and hematocrit, those are two ways to quantify the amount of red blood cells. So the complete blood count looks at red blood cells, white blood cells, and platelets. And it's everything we just looked at under the microscope. So when we're talking about white blood cells, each cell is a different kind of special forces provider to help with the immune system. If you have an elevated white blood cell count, there's a lot of different things that could be, but usually it suggests that there's some sort of inflammation or infection going on where you can see that the body is mounting an accelerated response to some likely invader. But it doesn't always have to be an infection or inflammation that the body's fighting. Sometimes these can be elevated just due to stress or to trauma. Frequently they're elevated due to steroid use, and then if they're incredibly elevated, sometimes that can be due to cancer or leukemia. Sometimes white blood cell counts can be decreased, and that can be due to something that the hospital or doctors have actually induced on purpose, like chemotherapy. sometimes you can see that the white blood cells just get outnumbered, and in sepsis they might be very, very low. Vitamin deficiencies can have low white blood cells, and then some infections actually target white blood cells and make those counts low too. The most common one would be, or most familiar one would be HIV. When we look at our red blood cells in the complete blood count, you might hear this referred to as H and H. The first H stands for hemoglobin, and hemoglobin is the molecule that has iron inside of it and carries oxygen to the tissues. And that is actually a quantifiable number that you will get back from the lab. Whereas a hematocrit is kind of more of a rough estimate, but is also a different way to measure red blood cell volume in the patient's peripheral blood. And hematocrit is essentially where you take the tube of blood, you place it in a centrifuge, spin it down, and just based on weight, the heavier particles, which are the red blood cells, will fall to the bottom. And then you can quantify the percentage of the fluid that are red blood cells. So like we mentioned before, for an average adult, it would be about 44% for an adult male. Now you can imagine, say this person is dehydrated. We know that their body water is located in the plasma. So if they're dehydrated and they have less body water to start with, it might look like they have more red blood cells when really they don't. They just have less water. When we think about anemia, there's different things that can cause it. One of the most common and that we see frequently in the pre-hospital setting is bleeding. But it can also be caused by iron deficiencies or different hereditary disorders. So if you look at these slides here you can see our normal peripheral smear. We have nice pink, round, red blood cells that are doing their job carrying oxygen. There's a whole lot of them around. It's not too thin. If you look over here, here's an anemia where the same kind of slice of tissue, you see way more plasma in there than you do red blood cells. And if you look a little bit closer at the red blood cells, they're very, very pale, and they have a very hollow center. And this is likely an iron deficiency anemia, where those cells don't have as much hemoglobin in them because of likely an iron deficiency. And down here, if you look, this is what sickle cell anemia looks like. You can see that the red blood cells, they're nice and pink, right? So it's not a hemoglobin problem and probably not a vitamin problem, but look what's happened. A whole lot of them are kind of folded over on themselves and they're sickle shaped. And so they're not able to carry oxygen like they normally would. And actually, that shape tends to get stuck in blood vessels and cause ischemic events as well. So this is what sickle cell anemia looks like under the microscope. Now, if we put that in the context of our patient, and we think about the blood that we have put in the centrifuge, and we know that all of our clotting factors are located in the plasma here, and all of our oxygen delivery capability is here with the red blood cells. But we know that our patient is losing all of this, right? So as they're bleeding somewhere, they're losing their clotting factors and they're losing their oxygen delivery capability with their red blood cells. Does it really help when all we do is give them fluid? Well, not really, right? Because this doesn't have any of the things that they're losing. They're losing clotting factors. They're losing red blood cells. We're not giving them any of that back when we give fluid. All we're trying to do is increase their preload to give them a little bit of pressure to get what red blood cells and what clotting factors they have left to where they need to go. What we really should be thinking about, and we're just not quite there yet, but we're getting closer, is giving them blood and giving them whole blood. Because we know that if they're losing clotting factors, if they're losing red blood cells, that's probably what they need to be getting back. And so what we're learning from a lot of the studies that are coming out of the wars that we've been fighting for the last 20 years, whole blood is safe and it's very effective for traumatic hemorrhagic shock. For us right now, it's more of just a logistical issue of how to make that happen. But I can tell you that there's a lot of interest in this in the pre-hospital setting because it's better for patients, and it just makes sense. If they're losing blood, give them blood back. Fluid's not going to help. Which is why you'll see in our guidelines that we try to limit our fluid resuscitation to just permissive hypotension, to where we can give them just enough fluid to keep their blood pressure around 90 to 100, not too much pressure, not too much fluid, so we're diluting everything, but enough to keep perfusion going. Another reason anemia is very important, you might see this in your patients, is that if they don't have, remember that it's our red blood cells that are carrying oxygen to the tissues, and so if we don't have enough little boxcars to carry oxygen where it needs to go, that's going to hurt the tissues, or namely the end organs. So the most important organs we have, obviously, the heart, the lungs, and the brain. So you might see any number of problems in patients who are profoundly anemic. They can have cardiac ischemia, even to the point that they're having a heart attack. They might have episodes of syncope or dizziness or lightheadedness. Usually they complain of trouble breathing, and they might be hypoxic. Again, that's because they're not getting enough oxygen delivery. The brain is especially susceptible to decreased oxygen delivery, so they might be confused or altered. Usually there's a profound amount of fatigue, and sometimes this can even lead to stroke. So if you're seeing these kind of signs or symptoms in your patient, don't forget to think about anemia as a possible cause. The last thing that we look at on the complete blood count is platelets, and these help with clotting. If you look at the electron microscope here, they actually, as they're patrolling the bloodstream, as they get activated by certain little chemical factors in the blood, they kind of grow these little sticky little legs, and they form the basis for a clot, and they can catch, you see them catching a red blood cell right here, and it helps to stop bleeding. This is what they look at like while they're resting, and then once they get activated through a chemical cascade, they get sticky and clumped together. And this happens anytime there's an acute insult going on, whether it's tissue trauma, whether it's inflammation, whether it's infection. Platelets will be activated and start to aggregate. And then sometimes platelets can be decreased as well, so they might be getting destroyed, usually by the spleen or the liver. The liver actually plays a role in producing platelets, and so if patients have liver failure, it's just expected that they're going to have a low platelet count. And then in dialysis patients, as their blood is constantly going through machines, their platelets don't work as well as normal platelets do. So that all those patients are prone to bleeding if they don't have the right number of platelets that can be activated. One of the things that you might see in the pre-hospital setting in patients who do have a low platelet count is called purpura. And this is a fancy term for a dark purple rash that's usually due to bleeding just below the skin surface. And that can be due to basically 3 different things. One is if there's a problem with platelets. 2 is if there's a problem with vessels. And 3, if there's some sort of coagulation disorder. The vessel problem is called vasculitis, and that's inflammation in the vessels. One of the most common places you'll see this is in children. There's something called Henoch-Schönlein purpura, and little kids, usually less than 10 years old, will usually present with a rash that looks like this one up here, associated with some joint pain, and it's usually due to a viral thing, and usually it can just be observed for a while, but they do present with a significant amount of pain and a scary looking rash, but not that uncommon in children. Now this one, on the other hand, if you see this, my advice to you would be to absolutely use your PPE and get a gloves and mask on, because this is more of a dissimulated purpuric rash that would be suggestive of a possible meningitis or sepsis. And that means that this patient is having such a profound inflammatory response that their platelets are getting consumed and they're starting to bleed just there underneath the skin surface. This is an incredibly sick patient. So if you see this in a child, probably just a simple thing that'll resolve on its own. But if you see this in an adult, I would absolutely realize that this is a very sick patient and make sure you're using your mask and your proper protective equipment. Another little note about platelets is this is why aspirin is very important in chest pain patients, because if you think about the heart and you think about what's happening in a heart attack, this is the big vessel that's feeding the muscle of the heart, right? And plaque builds up in there, and if one day, for some reason, this plaque ruptures, what happens when there's tissue damage is that the platelets come to the scene to repair the tissue damage. Well, you get so much inflammation around here as the platelets are trying to repair the damage that it can cause so much inflammation that the vessel is completely occluded. And so what aspirin does, this is a complicated biochemical pathway here, but essentially aspirin blocks the action of platelets. It makes them where they're not so sticky anymore so that they don't clog that vessel. And it actually helps keep that vessel patent. So that's why we give aspirin in a heart attack, is that it decreases the platelet function. And where it acts is actually right here on this cyclooxygenase enzyme to stop the clotting cascade. It's the only medicine we give in chest pain that helps with mortality. Okay, that's it for the complete blood count. We're going to move on to the chemistry now, which is everybody's favorite subject, I'm sure. But we're going to talk a little bit about electrolytes and why they're important. Essentially, when you think about the body is a little chemical factory, and it does all this chemistry all by itself, and it uses the charges on the electrolytes to make things run. If you think about a battery, there's positive charges and negative charges that produce an electrical current, and that's essentially the same thing that's happening in our body. Only difference is the body uses electrolytes to do that. So the most common electrolytes in our body are sodium and potassium, and they do this work of making energy in the solution, and the solution in our body is water. So if you look at the fluid compartments of our body is about 60% water, and most of that fluid is located in the intracellular space. And this is very important for later as we start to think about electrolytes. But if you look at the cell here and think about all the water living in here, so it's about 40% of the body weight. The majority of the water in our body is inside the cell. And this is the little chemical factory where there's all kinds of DNA being made and protein being made and all kinds of activity, energy, ATP. Think of this as a little factory, and the factory works best. Remember that battery, it's electrolytes working in a solution. So the more solution is inside the cell, the more efficient it's going to work. And then out here you have what's called the interstitial fluid, which is just essentially the space between the cell and the vessel. And here, if you think about this as a highway, so this is your vessel. There's a little bit of fluid in here. There needs to be, but this is more of a delivery vector for fluid and for electrolytes. And so you've got your vessel out here and your intracellular space here. Now, what's important about this is that inside the cell, where that factory is going to work and things are being made and there's lots of water, you have a whole lot of potassium. But outside the cell, inside the blood vessel, you have a whole lot of sodium. So sodium is going to be very prevalent in the blood vessels, and potassium is going to be very prevalent inside the cell. In fact, if you were to look at the numbers, if you were actually to count every molecule in the blood, you would see that from the extracellular fluid, which means inside the vessel, right? The number of little sodiums is 142, but the number of potassiums is only 4. That's a giant order of magnitude more sodium in the blood than there is potassium, right? But if you look inside the cell, it's almost exactly opposite, where there's a ton of potassium inside the cell and very little sodium inside. And what that does is it helps create an electrochemical gradient from the vessels into the cells, where if you move those charges, it can create some electricity and then molecules can be built. So very important to remember that sodium is outside the cell in the vessels and potassium is inside. Now, why do you care? A whole lot of chemistry. Well, a lot of what your patient is experiencing has to do with their water balance, whether it's dehydration or electrolytes. The body is going to be able to function if all these electrolytes are in the right order. So the reason that sodium is inside the vessels and there's such a large amount of it is because everything about sodium dictates everything that's happening with water. So if you look at the water molecule, it's H2O. You have oxygen and then 2 hydrogens here. Oxygen has a very negative charge, and hydrogens have a weakly positive charge. So overall, if you look at the water molecule, it's going to have a kind of a weakly negative charge, but sodium has a very positive charge. So what that means is we all know that opposites attract. So this positive charge of sodium is going to be very attractive to this water molecule, and water is going to go wherever that sodium goes. And that's the basis for osmosis. So water is going to move to where the sodium is. And if you look at this little beaker here, you can see if you have your evenly distributed water, but you have more salt on this side than you do on this side, the water is going to move to where the salt is, and then this side is going to be dehydrated. and you're going to have more volume over here. So what salt dictates is volume inside the vessel. And that's very, very important when it comes to the way our heart functions and how much blood the heart is able to squeeze to the rest of the body, because it's dictated by the salt and the water in the vessel. Here's another way to look at it. So if you look at a normal solution, you've got a little red blood cell, or maybe just a little cell surrounded by an equal amounts of water and equal amounts of salt. But if you look at an area where maybe there is not so many electrolytes, right, but there's a lot of water, what's going to happen is that now all of a sudden the cell inside, it's got all these charges. Remember, it has the potassium and everything that still has a charge as well. So water is going to move inside the cell, but it might actually rupture the cell and make it swollen and too big. Whereas in a state of dehydration, let's say there's less water because water's been lost through fever or breathing fast or sweating or whatever, that increases the concentration of salt outside the cell. So water, remember, our cells are a receptacle for water. The water's going to move out to try to balance out all the solute that's out here, and then that cell is going to shrivel and shrink and not be able to do its job very well. And that's what happens when patients are dehydrated. Patients can get dehydrated as the body temperature gets higher. They're going to be sweating. They're going to be losing water that way. As you're breathing fast, that air that you're breathing is humidified. You can lose water through that as well. And just realize that these patients that are losing water, those, as they get more and more dehydrated, those cells are going to be donating the intracellular water to the vascular space to keep the volume going. And in the meantime, they're sacrificing their ability to function at an ideal capacity. Another way that you might see this salt and water balance and why this is important is with your patients that have edema. So if you look up here at this first blood vessel, this is one that's functioning normally. You have equal amounts of hydrostatic pressure, which is just water pressure on the outside of the vessel, pushing on the vessel wall, versus the osmotic pressure, which is the amount of sodium inside the vessel that acts as a magnet and keeps that water in the vessel where it needs to be. So they balance each other out, and in this case, all of the water is staying inside the vessel with the sodium, and you have a good amount of intravascular volume. But if you look at your patients that get sicker, what's happening in this one where they're developing edema, this is because there's increased hydrostatic pressure, which means there's some sort of extra pressure on the walls of this vessel that's overcoming the amount of sodium that's in there to keep the water in. So this could be due to maybe a blood clot. This is why blood clots in legs, why the leg gets swollen, because there's so much pressure that vessel can't overcome the pressure, and then the fluid starts to leak out of the vessel. Or it can be due to congestive heart failure, where maybe blood volume just isn't circulating like normal. This is where you get edema. There's another cause for edema as well, and that's just if you don't have enough of a positive charge inside the vessel to keep the water in, and fluid just leaks out. And that can be due to decreased protein. You see this very frequently in liver failure patients where their liver is not able to make albumin anymore, and that acts as a magnet inside the vessel. And so without that magnet there to keep water where it needs to be, the water leaks out. So that's enough about sodium and water balance. It's very important. But the next most important thing is hyperkalemia. And so this is a way to say high potassium. And there's different causes of this. One would be ruptured cells. Remember, the amount of potassium in the cells is located inside the cell. So if the cell ruptures, you're going to get too much potassium in the bloodstream. Same thing happens if cells die. That intracellular potassium leaks into the bloodstream and can be deadly. Acidosis, as the pH of the body changes, the cell wall weakens. And then if the cell bursts due to too much acid in the blood, then the potassium leaks out as well. If the kidneys are failing, we see this very frequently with these patients that are hyperkalemic. The kidneys balance all these electrolytes and do a really fantastic job. And if the kidneys aren't working right, then too much potassium might build up. And then certain medications can do it as well. Just remember, if you have a patient that's at risk for hyperkalemia, then they absolutely need an EKG. These are some of the changes that you might see. Really, The textbooks will tell you that the different EKG changes will correlate with certain levels of potassium. I don't think that's true. Again, patients don't read the textbook. What you need to look for is these peaked T waves in the anterior leads. You can see these peaked T waves here. They look like big, tall mountains. That's a patient that I would treat with albuterol. Albuterol is most quickly and most effectively going to move potassium into the cell where it needs to be. You can give them a neb and it should do the job, and you can watch those T waves actually start to flatten out. The T waves are made of potassium, so if you have giant T waves, think potassium. As the potassium levels reach critical levels, the myocardium becomes unstable and you'll start to see a sine wave develop. This is incredibly dangerous, and sometimes as hyperkalemia gets worse, you'll see your patient get bradycardic as well. So if you see a bradycardic wide rhythm like this, think hyperkalemia. You're not going to have the typical clue of the tall peak T waves, but you can kind of hallucinate them over here in V4 and V5. What you need to give this patient right away is calcium. That's going to help narrow the QRS complex and stabilize the myocardium, but realize that is not going to move any potassium. So give them calcium first to stabilize that myocardium, but then give them albuterol to move that potassium where it needs to go and quit causing problems. One important thing to consider when we're talking about potassium, I know you're all familiar with rhabdomyolysis. It's a very common topic of conversation with the cadets out there as they're working hard every day. As muscles are breaking down, those are cells, right? And so if cells burst as you're working hard, that's a big release of potassium, but it's also a big release of a protein in the muscles called myoglobin. And myoglobin is a very large molecule, and it's very difficult for the kidneys to process. And so it gets stuck in the little parts of the kidney right here. You can see this big pink congested area here. Those are myoglobin molecules that are clogging up the kidney, so the kidney can't filter as good as it usually does. And that's bad because the kidney really needs to be filtering all that potassium that's being released by the broken down muscle cells. And so what you see happen is you get the tea-colored urine as the kidneys are starting to fail because they're clogged up with too much myoglobin. And then on EKG, what you're going to see is those tall peak T waves as the body's not able to process the potassium like it usually would. Lastly, is just quick talk about pH and capnography. We know that cells need three things to do their job. They need oxygen, which is delivered by the red blood cells. They need sugar, and all in an effort to make ATP, which is the fuel that drives the cellular activity. So if you think about the cell, for it to work, you have to have oxygen delivery by a red blood cell, and you have to have glucose present. And if both of those things are there, then the cell can go through a whole biochemical process to make whatever it needs to make and end up with a ton of ATP, which will fuel the rest of the cellular activity. But the byproduct of this is carbon dioxide. And so if cells are working the way that they should, they're able to make 36 ATP, and then there's a byproduct of carbon dioxide, which we normally just exhale without a problem. So here's another way to look at it. If you have your cell, you have your oxygen present, you have your glucose present. A lot of biochemistry is going to happen in here that you don't really need to worry about. But at the end of the day, you're going to get a ton of ATP, and the cell's going to do its job. Now let's say, for instance, that you have some problem with oxygen delivery, whether that's no red blood cells present or there's some blockage so the blood can't get where it needs to go, but you still have glucose present. What's going to happen is that body's going to kick into its backup pathway, and it's going to do its best to make ATP. But without oxygen, it's only going to be able to make 2 ATP molecules. So that's not going to last for very long, but it's a stopgap until things can get fixed. The important thing to note here is that we know that lactate is a byproduct of a situation where there's no oxygen delivery. And why is that important to us? Well, what it does is it tells us that for some reason there's inadequate tissue perfusion, and that's actually the definition of shock. If you have a cell that's not getting adequate oxygen delivery, you have a buildup of lactate, and then you have a patient that's in a shock state. And if you go back to thinking about the way that a normally functioning cell would work, you have your glucose present and you have your oxygen present, and that cell, if it's working just right, will make carbon dioxide and ATP with a byproduct of a little bit of water. Well, what that means for us is that carbon dioxide is an excellent measure of exactly what's happening at the cellular level. So if you have a normal level of carbon dioxide, that means the cells are doing what they should and everything's working normally. But if you have a low end tidal, this is why we measure capnography. And if you have someone who's in a shock state, let's say they're not getting enough oxygen delivery and they're building up lactate, your carbon dioxide levels are going to be low. And that might be an early indicator for you for a very sick patient that you might not otherwise recognize. So that's why capnography is a good thing, and we should use it with our sick patients because it's a really quick indicator of exactly what's going on the cellular level. So I know that's a lot of science, and hopefully I didn't go too fast, and hopefully it made sense. But if you have questions, please feel free to reach out to me or ask your 7-8. Thanks.